Hello, this is Arun Nagdev from Alameda County Medical Center, Highland General Hospital. This is the SAEM lecture series, and this lecture is ultrasound-guided central venous cannulation. So just the outline of the lecture, we're going to start with some basic assumptions and why we do central venous access with ultrasound. We'll discuss the data very quickly. We'll spend some time with the technique, and we'll discuss some tips, and we'll kind of summarize the whole thing at the end. So let's start. One classic blind technique, this is something I learned in residency when we're doing cannulation of the internal jugular vein. Classically taught to go between the two heads of the sternocleidomastoid, aim at the ipsilateral nipple. Nice article, 2003, now a little dated, but still proves a very important point that talks about the frequency of mechanical complications, and really the thing we're going to focus on today is arterial puncture. And we do see pneumothoraces as well, but really almost a 10% rate of arterial punctures is something that's fairly scary for us, and this is the reason why we're thinking ultrasound guided techniques may be useful. So the landmark based assumption, and we talk about this, is that landmarks are always present, that when we palpate somebody, the IJ is always lateral, and we can see and feel the carotids. So really, our landmark's always present. So in this, one of our techs in our hospital, really nice anatomy. You can see his sternocleidomastoid, you can see his clavicle really clearly, and there you can palpate the artery, and maybe you could be comfortable doing this. But one of our EMTs that maybe ate too many Doritos, a little more difficult. I can't even see his clavicle, having a hard time locating his internal jugular if I palpated it due to the little bit of adipose tissue. And again, more commonly, we're seeing this in our patient population that tends to be a little obese. So landmarks are not always present, and we know that. And the internal jugular, does it always lie lateral to the carotid artery? We're taught that. I was taught that in residency. You palpate the carotid artery, and lateral is the internal jugular vein. So really, is that true? So classically, if we're looking at ultrasound, here's the artery and here's the vein, and there's, as you see from the drawing, there's very minimal overlap. So if my needle comes in, I'll puncture the vein only. But there's a lot of literature, and again, that shows that the anatomic relationships are varied, and where you are in the neck, it depends how much overlap the vein is to the artery. So on the same patient that I'm looking at, as I scan up and down his neck, you will see that the vein slowly comes over and it causes complete overlap. So this same person, there is complete overlap. So if I'm palpating the artery and I'm sticking laterally, I won't get anything. And this is something that I think I did when I was a resident and missed a lot of these central lines. So again, landmarks may not be present. The internal jugular vein doesn't always lie lateral to the carotid artery, and carotid artery puncture is harmless. This is what I was told in residency. And again, is the carotid artery puncture harmless? When you look at this, there's a really nice case report about this, but when I was a resident, we'd puncture the artery, and I remember I was called a medical student, hold pressure. So this nice case report, and I'm sure there are tons of it. I've done this lecture for years around the community, and I've heard numerous people stand up and tell me their complications with carotid artery cannulation accidentally. And this guy punctures the artery, goes to the other side. The first side had a hemopneumo, and the patient arrests. I think brave of him to talk about his case report, but I think this is probably more common, these complications, than just hold pressure for a little while. So landmarks may not be present. The IJ doesn't really lie lateral every time to the carotid artery, and carotid artery puncture is not harmless. So really, and from this kind of concept, these practice implications are coming all over the place. The Institute of Medicine, the NHS, the AHRQ, all talk about how ultrasound guidance for central venous cannulation, specifically the internal jugular, is really something that we should adopt fully and recognize as a standard of care. So quick little up-to-date review, because I think it's relevant to our talk. This will be done quickly. Like most things in medicine, it takes about 10 years to 20 years for us to adopt technology that's been published in the literature. 1986, anesthesiologist demonstrating that this could be a useful technique. From the 2000 to 2010, we start seeing more and more case reports and in critical care and emergency medicine. And when you look at this in totality, let's look at critical care first, because I think they have the cleanest literature on this. There's numerous studies, everything ranging from 2002 to 2006. I do want to point out the article in 2003 that I think is important. And this is the May article. And really they talk about when the vein gets really small, anything less than a centimeter, your rate of complications goes much higher. This is with ultrasound guidance, which makes sense to all of us. The smaller the vessel, the more rates of missing it, and it's just a little more difficult. And I think this is, again, in novice practitioners. My senior providers are very comfortable looking at small vessels and cannulating them. And I think probably the most important article in this bunch, I think is the cleanest, is a study from Greece in 2006 where they had 900 randomized patients. Again, experienced anesthesiologists, non-moving patients, probably most of them were intubated. And you can look at the success rates higher with ultrasound guidance than blind, 100 versus 94%. But I think the key on this slide is that 10.6% arterial puncture versus 1.1 for ultrasound versus blind, which is impressive for sedated, intubated anesthesia patients done by high-level providers. If you look at the emergency medicine literature, and I think the best article in this group is the 2006 Leung article. Again, higher success rates with ultrasound, lower rates of arterial puncture. So again, proving the point, and I think this is a fairly obvious point, that ultrasound or visualization of what you're doing is going to reduce your rate of error. So how do we do this? What's the procedure on this? And I'm going to try to run through this. What probe do we use? And this is a high frequency linear probe, you'll see. And I think the key on this is to recognize the probe marker, because the probe marker is very, very important. And you'll see in the next slide, the probe marker should align here with this little blue dot or the whatever symbol on your ultrasound machine. So you know that when you move to the left, you'll be towards the left, and stuff on the right is towards the right. Very important. Again, apply gentle pressure. You can see how this hand is resting almost on the clavicle. This is in a transverse plane, so you're seeing everything transversely. And again, reminder, screen marker should match the probe marker. And again, when you're looking at this, I think it's key to recognize the three important structures here. One is the thyroid for the beginner. 2 is the carotid artery, and 3 is the internal jugular vein. And you'll see, I think this is, for a novice provider, locating the thyroid is kind of a useful tool. I think as you become more, you do this more often, this is not something I look at ever, but it's nice to know exactly where you are on the neck. So again, let's just go over these. 1 is your thyroid, 2 is your artery, and for the beginning provider, this is for the experienced provider, this is fairly easy, and 3 is the internal jugular vein. Again, the vein is going to be more collapsible. This is clearly your right internal jugular vein. So teaching point 1, so look before you leap, and I always talk about this. So this is your patient, you're about to put a central line in, and I think looking at both sides and finding the best vein, the least amount of overlap, is the best thing to do and the smartest thing to do. So case 1, urosepsis, needs the whole process. We're going to put a central line, this lady, measure a lot of stuff with early ultrasound therapy. And oh, by the way, she has an INR 7. This is one of my patients I had a couple years back, and it was fairly impressive. So my resident scans up and down the right neck, and you'll see she finds the artery, but can't find the vein. She's scanning up and down the neck, and eventually she's going to scan all the way down the neck and see kind of a large mass-like structure here. It ended up being a thyroid mass that was undiagnosed, and we actually ended up diagnosing it, and it collapsed the vein. She went to the other side, her left side, and beautiful vein that you can see, easily cannulated and moved on. If we were to stab that lady's if we were to prep that lady and then started the process, we would have not found a vein. Or if we were done it blind, we would have probably hit this thyroid mass or just not been successful. So always look both sides if you can. If you find it on the right side, which I think is a better side, then go for it. But if you can't see it, move to the left. Case 2. So this is, if you guys, this is kind of an interesting case because this happened twice now. This is a patient with sore throat, progressive neck pain. And for all you EM geeks out there, this is an interesting case of a young male with really bad sore throat who came in looking meningeal to me. You can see on the left neck, he has a thrombosis of his IJ. So I'm glad I didn't go in that side. And then if you look in the right neck, you'll see a beautiful patent vein. This is actually the valve because I'm pretty low on the neck. And if you know, this is Lemire syndrome because this guy has thromboembolic events from his thrombosed IJ. So it's a really interesting case and something that, again, looking at both sides of the neck makes a huge difference for me. So sterile technique, how do you do this? People always ask me this. The two-person provider technique. One person, again, is going to be holding the sterile cover sheets. Your nurse or your assistant can put the probe inside the sheath, and then you can slide it over slowly and then put it on a sterile field. So you have a nice sterile probe. Or if you have one person, this is Dr. Cook from Portland showing this technique, puts his hand in and then just grabs the probe, which he's already set up, which is a really nice technique if you're by yourself, and then slides it over. So this is another technique. Again, either one works as long as you keep the area as sterile as possible. And so the classic short axis technique, I was told when I was taught this, is to follow the needle tip as you progress. And you'll see as you enter, you're supposed to move the probe farther back and follow the needle tip. The problem with this technique is you're really doing three things at once. You're looking at the probe, you're looking at the ultrasound screen, and then you're puncturing the skin. And for a beginning sonographer, I think this is very difficult. Even for more advanced sonographers, I think this can be very difficult. And I think for this reason, or because of this reason, we're seeing some ultrasound guided complications. And this is a very nice study done by Dr. Blivis and Adhikari in Critical Care Medicine 2009, where they kind of watched their residents doing these central lines with another ultrasound machine. They actually used an endocavitary probe, and they showed in about 64% they actually punctured the back wall, and that's because they're following the needle tip and having a hard time doing so. And in these, 5 of these had carotid artery punctures. This was on a phantom dummy. And then Dr. Blivis again publishes in Journal of Ultrasound Medicine that in these cases of inadvertent arterial cannulations, again, they were all performed in short axis, and all these patients were hypertensive, which makes sense. Their vessels are small. And really, when you look, this is going to be a problem in patients that have complete overlap. Now, this person's got a very plethoric IVC, an IJ, but if it was completely flat and you'd puncture through, it would be really easy to hit that artery in a transverse view. And I think this happens because you're spending too much time trying to find the needle tip, and you're not an advanced provider. You haven't done hundreds and thousands of these like the anesthesiologist, and this is going to be a lot of hand-eye coordination. It's very difficult. And for that reason, I kind of developed the modified short axis technique, and this is something that I think is really kind of intuitive. So really, using your basic geometry skills, you're going to get this idea. So here's your probe. You visualize the ultrasound, visualize the internal jugular about 2 centimeters deep, back it up 2 centimeters. At a 45-degree angle, you're going to puncture that vessel right underneath your beam. Instead of putting the probe here and sliding it up and doing 2 or 3 things at once, you're very stable. You know exactly where to go. You know how deep to go, and you should puncture. It's very simple. And again, same idea. Again, look at how deep you are, find how deep the vessel is, track it back the same amount, and about a 45 to 60 degree angle, if you come in, you will puncture the vessel right underneath the ultrasound probe. And that's the beauty of this. It's not that hard, and it allows you to have one hand stable, and you're not spending too much time looking at the needle. So again, here's a nice ultrasound. You can see that these markers, this is great because it gives you a depth marker right to the side. And again, you're going to know, and you can calculate 1, 2, 3. So again, this is the total depth. So this is your ultrasound machine. Everyone's different, but they'll probably tell you the depth. And you can see this is a centimeter deep. Go a centimeter back, puncture to 45 to 60 degree angle, and you'll be in the vessel quickly. So again, I always tell my residents, don't do it this way. If they're trying to visualize a needle tip, if the vessel is a centimeter too deep, the needle will pass this point and puncture over here where they're not looking. So I always tell them back it up a little bit. If you back it up, you're gonna get a much better chance of cannulating that vessel. Measure the depth and go that far back. Again, another point I say is always scan up and down the neck. Make sure that you're visualizing your ultrasound, your vein in a true long axis. So again, here's your vein in this blue schematic. And let's say I was scanning in this direction, thinking this is where the vein is. You'll see the ultrasound, the vein will kind of fall off my screen. That means it's not in the middle. That means this is not the true direction. Now I rotate that probe into the longitudinal direction. You can see how the vein stays in the middle of the screen. That means that's the direction of the vein. If I know that's the direction of the vein, then you puncture, place the probe perpendicular and puncture in the same direction. So scan up and down, make sure that's the direction, and then puncture in that direction, because you'll get a nice long axis of the vein. Again, if the vein is tilted in this direction, then you want to rotate your needle and go in plane or in the same direction as that vein. Hope that makes sense. So again, here's my resident puncturing. She's about a half a centimeter back. She's going to get access. And right when she gets access, I think the most important thing now is to confirm venous placement. So we classically talk about chest x-ray and venous blood gas being a good tool to tell you if you're in the vein or artery. Not true. Not accurate. And we know this is false. Chest x-ray rules out a pneumothorax. A venous blood gas is not an accurate tool. And really the best way to do it is to measure central venous pressure. And that's great if you can get the monitor up in 20 seconds, but then you'd have to place the needle in, dilate, go through the whole hassle. And then, like when I was in the old center, we recognized somebody had a CVP of 95, and you know that's arterial. By that time, you've already cannulated and dilated the artery. So we developed a thing called ultrasound-guided venous wire cannulation visualization. Excuse me, let me repeat that. Ultrasound-guided wire visualization. And you'll see here, after my resident has obtained access and started to put the wire in, here we go, very shallow puncture. Good. We know that we got some kind of blood. Then the wire goes in, and once the wire goes in, the probe comes back. And you can see here, there's the artifact of the probe right there, the wire, excuse me. You see the wire giving a little echogenicity right there. And if you turn it longitudinally, you can also see the wire very clearly. And again, that confirms it's in the vein rather than in the artery. I think it's a really simple technique. It's very nice, and it's done before you start the dilation process of the vessel, which I think is the key, because this wire is smaller than an 18 gauge needle. So case 3, apparently nobody listens to me at my center. So here's the central line placed. We're on rounds. We've come, the nurse is about to start dopamine on this patient because of her her severe sepsis. And you can see my resident throws the probe on there and notices that here's the artery. Now, is that the catheter in the artery? Yep, yes it is. So this is an arterial cannulation. You probably don't want to put too much dopamine or levofed into an artery, probably a bad form. And again, now we have this nice big line in the artery. Do you pull it, compress it, or do you just leave it there? And this is something that I didn't know about until I started looking up the data. Again, here are your kits, the classic triple lumen and the classic single lumen. Single lumen, the big cortices, big, huge 8.5 French, and our triple lumen is a smaller 7 French. Nice article out of Canada looking at they call it the pull pressure technique versus the surgical technique. And they really show the complication rate. And they talked about some crazy complications such as large infarctions in the brain because of lack of flow. Really showed and really recommended, as per the American and National Society of Vascular Surgery, not to pull these if they're 7 French or larger, but rather get consultation and then decide what you want to do. Again, at my center, getting a vascular surgery consult, if I put a line into somebody's artery, is a nightmare. So really easy technique. Just confirm the wire, because the wire is a small caliber line. You have not dilated yet. So here you can see I'm confirming the wire. The wire is in the IJ. Great, I know that. Now, then I can start that dilation of the vein. So this is just a really easy way to prevent that conundrum of having a large line in an artery and then having to call vascular surgery. So real quick summary. 1, look before you leap, scan both sides of the neck, transverse, simple. 2, use your geometry. Find how deep it is, step back that same amount, 45 to 60 degree angle. 3, always scamp it down the neck and make sure that you're in the same line as the IJ, so you're going the same direction, and then puncture in that direction. And 3, always find your wire before you dilate. I think this is more important in hypotensive patients and patients that have overlap. Simple technique, simple thing to do, and you're good to go. Anyway, thank you. This is Dr. Nagdev.